Welcoming everyone to our 2013 Fall CBC Health Braintrust. Thank you for coming. I hope you've all enjoyed the video montage that we had playing during the breakfast period and that you had a good breakfast. It's going to be a long day, packed day. So if you haven't had your coffee, tea, or fruit, please help yourself. There's a lot of it there. But before I go any further, I want to really thank some key individuals. First and foremost, the town hall that you saw in the video, as well as this Fall Braintrust, could not have been possible without the Centene Corporation. You know, I do have to say something about this company, Michael Nydorf, the President and Chief Executive Officer of Centene, who you'll hear from later, and Joyce Larkin, their Vice President of Corporate Community Relations. To most of us, though, here, Joyce's family. She's a graduate of the CBC Health Braintrust when she worked with the Honorable Louis Stokes, our Chair Emeritus. And so, Joyce, where are you? We really want to thank you. Let's give her a round of applause, because throughout the town halls and today, she's been the wind beneath our wings. I also want to thank Carl Garrett, who I don't think is here yet, but oh yeah, there you are. Hi, who also went around the country with us for the town halls. Under the leadership of Mr. Nydorf and with sound counsel from Joyce Larkin, the Centene Corporation and Centene Foundation has proven to be completely committed to health equity, to health disparity elimination, and more importantly, to ensuring that every American, from those in the U.S. Virgin Islands to those in Oakland, California, that they have the accurate, unbiased, factual, and user-friendly information that they will need to make the best decisions about their health and enrolling in the access expansion provisions that are included in the Affordable Care Act. This partnership has been one of my office's favorites and most memorable, because in every sense and at every step, it truly has reflected what happens when passionate and dedicated individuals find common ground, respect each other's expertise and perspective, and work together to make truly extraordinary things happen. And I have to also add a word of special thanks to Dr. Britt Weinstock. Is she still in the room? Because without her, she put all those town halls together, all 8 or 9 of them, and this brain trust that we're going to participate in today. So thank you, Britt. But speaking of extraordinary things, that's precisely what happened with the Making Good Health My Reality town halls. You will hear a lot more about them during the lunch, and we have brought 2 of the more popular items of those town halls to you today. The Making Good Health My Reality resource booklets, which are on the stands outside, and the Farmers Market, which will open up at the end of the Brain Trust. You really want to stick around for that. It's a free Farmers Market, compliments of the CBC Foundation and Centene Foundation. But let me go back to the schedule and our agenda for today. The final copy of the agenda is on your chair, not the one in the folder. We have a very full and very dynamic day planned, and so I'm really pleased today to be joined by so many health equity warriors from the community, local, state, and federal level, from the research and advocacy worlds to the provider and legislative realms. This year's Fall Health Braintrust really is a coming together of great, great minds. It is a very crucial, and it comes at a very crucial time in our nation's health and healthcare history. Seems like I say that every year. But it gets more crucial and more critical every time we meet. We thought we had won the battle 3 years ago, but we're still fighting. So this is a really critical time that could decide which way we go with healthcare in the future. So we're going to be discussing under this year's theme, Achieving Health Equity After the Affordable Care Act, Stories of Success, Lessons Learned, and Current Challenges. This morning we're going to begin with a very special panel that convenes African American healthcare providers from across the healthcare system. This panel, which is entitled The Role of the African American Provider in ACA Access Expansion Efforts and Beyond, will focus on Black healthcare providers' perspectives now that healthcare reform has been passed and is being enacted. Moderated by our good friend and resource to the CBC Health Braintrust, Dr. Joya Creer Perry. This session will also explore how African American healthcare providers can leverage their influence and expertise to become more effective in the health policy making process. I'm really excited about this panel as a physician myself, so I look forward to it. Following the special morning presentation is our first session of the day, entitled Post-ACA Reimbursement, Payment, and Funding Policies, the Health Disparity Impact, which was born out of numerous discussions, letters, and meetings that we had with CMS and other agencies in the weeks, months, and years after the passage of the Affordable Care Act. I realize that it's never intentional, but the reality of many reimbursement, payment, and funding policies that have been implemented in the post-ACA era have been and may continue to be challenging to larger efforts to reduce certain racial and ethnic health disparities. You'll hear from two experts on this topic this morning, and I want to thank David McIntosh and his team at Mayor Brown, Darren Parks from Davida, and Paul Brathwaite from the Podesta Group for making this session really come together. At 11 today, we have another special presentation entitled The Patient-Centered Outcomes Research Institute, PCORI, Lessons Learned Around Health Equity and Health Disparity Elimination. This is a panel that I've really wanted to organize for quite a while because this institute, the PCORI, is truly thinking out of the box and has the potential to play a very key yet largely unknown role in moving the health equity ball in the right direction. And so I'm pleased that we have Mr. Cuello and Dr. Frida Lewis Hall here to share important and very relevant information with us. In session 2, we have to thank Lionel Coates and Pete Norman from ASI, Mariko Bennett from Baxter, and Paul Brathwaite again from the Podesta Group. These brilliant individuals played such a pivotal behind-the-scenes role in ensuring that today's session 2, entitled New Partners in Health Equity, How Corporate Executives Are Joining the Health Equity Fight, was included on our agenda. It's very important because we often forget that the corporate sector does in fact have a very important place in the health equity fight. And many companies are stepping up and playing a socially responsible and very powerful role. So we'll hear from a few today, and I hope that we can all, listen and participate in a discussion with them, because we have to put the politics of cynicism aside sometimes, because we can't achieve health equity without the help of old, existing, and new partners. During our lunch, several of my CBC colleagues are to join me, those who hosted the town halls and participants in those events as well, to talk about what we heard from folks in the communities that we visited, what we learned, and what we know we need to do to make good health everyone's reality. I also want to thank Dr. Tricia Newman from the Kaiser Family Foundation, who will be here to share findings from a brand new report about income, assets, and home equity among current and future generations of African American, Latino, and white Medicare beneficiaries. I think it goes without saying that reports from Kaiser, and especially those that Dr. Newman authors, are reports that we all keep as valuable sources of information, and we're really honored that they're going to be releasing that report with us today. Let me also thank Mr. Everett Cunningham from Quest Diagnostics and AJ, who we all know, a definite graduate of the CBC Health Braintrust, now with the Podesta Group, for the compelling presentation that we're going to hear at lunch about Quest's comprehensive plan to improve minority health outcomes in diabetes, heart disease, and certain cancers. Of course, as we do at every Fall Braintrust, we'll be honoring several individuals with the 2013 CBC Health Braintrust Awards. Please stay, because these individuals are truly deserving, and we want you to help us honor them at lunch. Following the lunch, we have a panel that Dr. Weinstock has told me has garnered quite a bit of interest. And in light of the very unfortunate and tragic, very heartbreaking incident in Washington on Monday, this session is really timely. We have a session which is entitled Mental Health in Minority Communities, Current Issues and Effective Strategies to Reduce Mental Health Disparities. So I'm pleased that we've assembled a very well-informed and diverse panel whose presentations are coordinated to address this vitally important issue. I do also want to thank Mr. Terrence Thompson and Attorney Daniel Dawes, both of whom played a critical role in ensuring that this panel also really came together for us. Following the panel, a very special session that we're doing for the second time, Dr. Fredette West, who we all know from the time that she worked with Congressman Stokes, will lead an open conversation and dialogue with the audience about what the next version of our Health Equity and Accountability Act should include. She'll be joined by senior congressional health staff and other lead health equity advocates. And the purpose of that session is to engage all of you, our health equity champions, in the health equity policymaking process as it happens. And that's vitally important to us here at the Braintrust because we learn from you. Your perspective and expertise matters a lot to us, and we're pleased that we have those who are on the front lines here with us to engage with you in a meaningful dialogue around an issue of such mutual importance. And after all of that, we'll wrap up and take your suggestions for where we go from here. As I mentioned, I hope you will all stay with us for the day because we do have a farmers market that will open at the end of the Braintrust. It's our way of saying thank you. It's also our way of helping to make good health our reality. And that's compliments of the foundation and Centene Foundation. So I've covered the day. Again, I want to thank everyone for coming. And now I want to just introduce Dr. Marjorie Innocent, the Vice President of Research Policy and Programs at the Congressional Black Caucus Foundation, who's here to bring greetings and welcome on behalf of the CBC Foundation.
Good morning, everyone. Nice. How are you? You enjoying the conference so far? Wonderful. Very, very happy to hear that. And Congresswoman has already obviously talked about the program for today. You've heard an overview of what we accomplished with the health town halls that we did. And we're really excited about this effort in particular because it really allowed us to be able to expand or continue to expand the work that we do in partnership with the Health Braintrust to bring vital information to local communities. And in particular at this time, at this particular juncture, with October 1 coming up, there are some very critical provisions, as you all know, of the Affordable Care Act that will really help to move us closer to health equity by expanding health insurance and expanding community-based health care that people really need to understand. And this includes, obviously, the people who will benefit the most, but also those who are continuing to try to push back, right? And to say that we don't need all of this. The reality is it took us a long time to get to where we are in terms of health care, in terms of our healthcare status and in terms of outcomes. It's going to take some time for us to be able to change. And with these provisions that are coming up in particular, it's really going to be critical for people to understand why they were constructed the way they are, how it is that they can benefit, and how they should be prepared so that they can really be able to come to a place, I think, where they can really benefit from these provisions and come to a place also where they're going to be able to thrive rather than just survive, because we've got too much survival going on, especially in our communities. And so I want to echo what the Congresswoman said and really thank Centene Foundation for Quality Healthcare for their partnership around that effort and everything that we'll be doing moving forward. And also wanted to mention some of the other sponsors, obviously, for this event, as well as the overall work of the Health Braintrust and the work of the foundation as well, including Baxter, Lilly, Merck, Pfizer, Quest Diagnostics, WellPoint, and others. And obviously, we also continue to thank them for the work that they do every day to really help to improve the health of our nation. And obviously, I do want to say a big thank you again to all of you. I think you're really continuing to demonstrate your commitment to health equity and to really coming together to really be able to advance our country. So thank you. I wish you a very productive day. I do apologize. There's a lot going on. Got another session that I have to go and lead off to, but I will come back and look forward to seeing you later. Thank you so much.
Thank you, Marjorie. Yes, I know you're busy. So I'd invite our first panel to start coming to the podium, please. And the bios are in your folders. But this panel is going to be moderated by Dr. Joya Queer-Perry, who has a busy practice in obstetrics and gynecology and runs a multi-specialty practice in New Orleans. She was previously Director of Clinical Services for the City of New Orleans Health Department, but she continues to work to improve access and availability to New Orleans citizens. She's a fellow of the American College of Obstetrics and Gynecology. She's received many recognitions and honors. She currently serves on the Board of Trustees for Community Catalyst and the National Medical Association. She's married to Dr. Andre Perry and has 3 children. Her love is her family, New Orleans is her passion, and medicine is her calling. So help me welcome Dr. Joya Perry and the panel for the first discussion.
Good morning, everyone.
Good morning.
Welcome, welcome. I'm excited to be here once again at the Health Braintrust. I want to thank the Congresswoman for inviting me, and Dr. Britt, I don't know if she's still in the room. Once again, we are really pleased to be here. So good. So I won't read everyone's wonderful bios because they're long. They're inside of the folders that you have. But we're going to start really talking about physician advocacy and provider advocacy and how we can be more involved in the changes in healthcare. A lot of times we get left out of the conversation. Things happen and they're happening around us and we're not allowed to be able to participate. Can you guys hear me pretty well? So this is really an opportunity to say, okay, these are the things that are going on and how can we improve that and how can we participate? I want to let the panelists all know that I'm good at cutting people off. I asked my husband. So we only have about 45 minutes and all of you are very bright and wonderful folks. And so if you start talking a little long, I'm probably going to say, can we move on? It's not that I don't love you. Okay. So with that being said, I'm going to go with the first question. I didn't print them out, so I just have them. I hope you don't mind. I'm going to look on my fancy new upgraded iPhone that my daughter didn't think I could learn how to do, but I did it myself. Okay, so the first question is, as healthcare providers, what are some of the barriers that you recognize you contend with that impede your ability to be at the table, that's what we just talked about, so to speak, during the healthcare policy development, negotiation, and passage process? Who would like to begin the at the table conversation? Want me to pick? Oh, Dr. Lenore, yeah, right.
Well, thank you for the opportunity to join the conversation. As the president of the National Medical Association, we're extremely excited about the Affordable Care Act. Having practiced in underserved areas most of my career in both specialty and primary care medicine, I've seen the inadequacies of our ability to care for the underserved, and I've seen families broken and beaten down by the cost of care for coverage that was inadequate. Having said that, we as African American physicians are concerned about a number of issues. Clearly, we should have been more aggressive about being at the table. But in California, we're ready to go. They are on the starting line like Usain Bolt. October 1st, everything starts. But a couple of issues have arisen in California that will arise in your states. First of all, there's an issue on the essential community provider. That means that the definition of essential community provider suggests that you have to have a relationship with the federally qualified health centers or you have to have a relationship with the community clinics. That leaves out many of my colleagues who for years have taken care of these very same patients, such that now they are not considered essential. And in California, they've kind of retweaked the definition so that if you've done meaningful use through the EMR process, then you can be considered essential. As important as that is many of the health plans, the so-called accountable care organizations, have cherry-picked completely around the African-American physician. They've come into our community, they have set themselves up to get the low-risk Medi-Cal patients or the low-risk patients that will be covered by the Affordable Care Act, leaving the high-risk patients in the African-American community. We're more concerned about the patients than we are concerned about ourselves because we are the connection between them and their health care. We're the trusted providers that have established relationships in these communities. Yet not only have we been left out of the ACOs in California, probably if you're not at the table in your states, and we would estimate that 25 to 30% of African American physicians who practice independently will lose their practices over time if that definition is not expanded or changed. So those are a couple of the issues. The final issue, I think, for our patients is we really have not been aggressively included in the enrollment process. I have 5,000 pediatric patients, probably as many allergy and asthma patients, and they have parents and family, and I've got 15,000 people that I would connect with, yet we've not been aggressively involved in the enrollment process. There's been no resources provided for providers until recently so that we can inform our patients and help them to navigate through the system. These are just a few of the problems. They're minimal as it relates to the overall outcome of the Affordable Care Act, but they're very important for us. And if you expect to see your children or your relatives, or if you expect to see African American physicians in communities in active practice, then I think that we're going to have to be more aggressive about trying to redefine or retool or be engaged in how this program is refined.
Thank you, Dr. Lauren. And I think, to that point, we were really excited in 2010 when it passed, but now is an opportunity for us to make some revisions because we know it can have some improvements. And so right now we want to hold on to it. We don't want to let it go, but we can do things like change some of the definitions and expand some of the lessons learned for outreach and enrollment. So hopefully we'll be at the table for some of those kind of conversations. Okay, so Dr. Gorham, I have a question for you, if you don't mind. Okay, workforce development is a major component of the ACA. What new role will and should nurses and other healthcare providers play in implementation of the Affordable Care Act?
Thank you very much, and good morning to everyone. And before I get started, can you hear me? Okay, great. Before I get started, I wanted to give a shout out to all of the nurses who are in the audience. And to our president who is here, Reverend Dr. Deidre Walton. The Affordable Care Act has afforded the nurses a way to expand their role. One of the things that you should know, first of all, is that there are about 4 million nurses in the country. And out of that 4 million, there are 150,000 African American nurses. And out of all the nurses that are in this country, there is still a nursing shortage, which means even with the expanded role, even with the physicians, even with the primary care, physicians that will be working side by side with the nurses, there's still going to be more nurses that are going to be needed. The Affordable Care Act has been important for nurses because it expands the role of the advanced practice nurse. One, it provides provisions to increase the number of nurses by about 1,500 nurses through the National Health Service Corps. That's number one. Number two, of that 1,500, they're looking to expand the advanced practice nurse or the nurse practitioner by 600. Those are the nurses that are going to be able to provide primary care services. Those are the nurses that are going to help us move towards wellness and prevention promotion. Those are the nurses that are going to keep us, hopefully, healthy and out of the healthcare system. But when you are in need of it, it will be there. They will be there for you. The National Health Service Corps has been expanded. Their role has been expanded in such a way that there's more money for nurse loans, for nurses to go back to school. One of the things that the nursing community did back in 2010, it had a report that came out called the Institute of Medicine Future of Nursing Report. In that report, it talked about 80% of all nurses should be baccalaureate prepared by 2020. So if that's the case, then we need to have more faculty members. We're going to need to have more clinical sites. And the nurse practitioners will be moving into roles through the managed care clinics that they will be managing. You will be seeing more of those nurse-managed clinics, which is a provision of the Affordable Care Act. You will be seeing more of those nurse-led clinics in places like Walmart. You're already seeing them in Costco, because that's where people shop. That's where people are going to be getting their health care. And so as we're moving towards expanding the role of nurses, one of the major issues that comes up is to make sure that nurses can practice to the full extent of their training and education. So what's going to happen with that is that we're going to have to go back to the state level, like Nevada, like Iowa, that have already begun to expand the role of the nurse practitioner. We just want to make sure that nurses can practice to their fullest extent, side by side with healthcare, with their physician colleagues at the primary care level, to make sure that they're getting everyone is getting the best care possible.
Thank you, Dr. Gorman. Appreciate that. Once again, okay, so I hope you guys in the audience are starting to think of questions that you have, because we're just going to have a few, and then we're going to open it up to the audience. So, we have experts here from providers in research, in dentistry, and nursing, and so I just, hope you've read the bios, and I'm thinking about questions around the ACA for these folks, okay? All right, so the next question, I think, is a Dr. Puckering kind of question. All right, so how are healthcare institutions and entities, and it doesn't have to be for you, Dr. Puckering, how are healthcare institutions and entities, particularly those that serve a disproportionate number of African Americans and other racial and ethnic minorities, low-income individuals, and or un- and underinsured individuals, preparing for the influx of new patients? So if you don't want that, we can, yeah.
First, I want to say good morning to everyone, to Congressman Christensen and to Britt back there. Pleased to be a part of this. I'll quickly say I am not a provider, and if I start issuing you any care, you are in very serious trouble. What we do is we've been looking at the numbers, and obviously some numbers that pop to mind immediately. So in the typical American primary care practice, they're seeing about 3,000 patients. Minority physicians are seeing somewhere between 5,000 and 6,000 patients. A lot of it has to do with how they get reimbursed, and so they're trying to increase volume in order to make up for the differentials in reimbursement, particularly if they have large Medicaid practices, where that tends to happen. So what's going to happen is healthcare reform is actually about to happen in 7,000 zip codes. In those 7,000 zip codes, about 15 million minorities are going to come in for continuous health care, having not had health insurance before. They're going to come into practices which are already really having difficulty in terms of the hours and number of people they have to serve. I don't see anyone really having addressed that issue. Mm-hmm. It is not surprising to hear that there's cherry picking going on, because the marketplace is changing. A new consumer base, if you will, is coming into the market, and lots of people are going to go after it. I think there's the opportunity, though, is that minority providers have real leverage, but that they're not using. Mm-hmm. It is not surprising to hear that outreach is not being made to them in terms of recruiting patients into the exchanges and looking at expanded Medicaid. But I think if they talk up just a wee little bit, the opportunity will be there. Mm-hmm. And here's what's very, very important about the Affordable Care Act that I think is really quite profound. Health plans have to get each patient one at a time. Historically, we've had an employer-based system, and in an employer-based system, the employer is the aggregate, and so the insurer sort of looks to the employer as their client. In this model, the consumer is the client. You get to change plans if you don't like what they're doing or the services they're providing. That is going to change the business model for insurers, and they're going to look for partners to help them retain members, because what they're quickly going to find is that it's going to be cheaper to retain a member than to get a new one. That's the leverage point that all providers have. And in their negotiations, you shouldn't negotiate anymore as if you're dealing with an aggregator, meaning the employer has aggregated and delivered the insurers the numbers, and you have to accept the bargain that's being offered. Now you got the leverage point, and that changes. So I urge providers to think about themselves in a very, very different way, and don't be afraid to make outreach, because this new consumer base has to be served, and you want to make sure that minority serving physicians and institutions get the benefit of that. And I think that's really where the model has changed significantly.
Thank you very much. And to add on to that a little bit, so I know, for example, in Mississippi, where Centene is one of the great participants in this meeting, there are two organizations there that manage Medicaid, and the providers have a preference for Centene, and the patients are on Centene's plan. And so it's already starting that people are figuring out, they can actually tell the patients, look, this is really important. This is the plan that really services you and services your needs and services the needs of the population. And so this is where we think you should go. And every study shows, and I'm sure Dr. Pucker will agree, that patients listen to their providers, that they want to hear us talk about the ACA, they want to hear what we think about their health insurance. So we have to educate ourselves in order to do that. Okay, so this one I want to talk to Dr. Chappelle a little bit about the, because really with the ACA, it was because dentistry is not really a part of insurance a lot of the time. Sometimes it's kind of a separate conversation. It's definitely not a part of hospitalization. And the big cost drivers are hospitalization and insurance. A lot of things weren't addressed with dentistry with the ACA. If you were to see some changes going forward, what would you like to see for dentistry to improve access? Because we know we have a huge problem, especially in the minority community when it comes to the numbers of providers and access to dental care, dental services.
Absolutely. Well, good morning. And I'd like to say also my board of trustees and our officers are here, so of the National Dental Association, so good morning to them and thank you for coming this morning. One of the issues obviously with the Affordable Care Act is that dentistry was essentially left out, and the reason for that is our majority counterpart had a little something to do with that, where they decided they didn't want to be involved with it. So as of this point in time, pretty much only children up to the age of 19 are really going to be covered under that. That creates a whole gap of people from age 19 on up until you pass.
Right.
So we're talking about adults, we're talking about seniors. Seniors in particular are really getting the short end of the stick because many of them are retired, have no means, and have no way of being able to get dental care unless they had a job that they retired from and still retain that. But those that are of low income really don't have an opportunity. So we're talking about a quality of life issue for them. Not being able to eat properly, not being able to get proper nutrition because they can't take care of themselves. Which is a big issue. And when you drop down into the working age, okay, again, it's a quality of life issue where you're also talking about people who can't get a job, they have no teeth,
right.
And they don't want to smile, they don't want to do those kinds of things. And we're not only talking about that, but we're also talking about the pain and suffering that goes on from people who have toothaches and the amount of time lost from work and other kinds of things. So if we're talking about something that needs to change, we really need to make sure that we're covering as many people as possible so that we can deal with that, so we can deal with the quality of life. The mouth is a gateway to the rest of the body, and if you don't have proper nutrition and you can't take care of yourself, then what's going to happen? It leads to other illnesses, and that is an issue. So.
Thank you. And so I also know that they've done a lot of studies about how ER usage is a lot around dentistry. And so it is interesting that they're not addressing how many people go to the emergency room for dental issues, for abscesses, for broken teeth, and they want to decrease ER costs without addressing that specific issue.
Well, when you deal with those numbers, it's just kind of staggering. They have found that when people have proper dental care, that the number of ER visits go down, and that when people actually go to the ER to get dental care, it's limited care as it stands. So, and basically, they're still referred back to a dentist at some point in time. So, and the amount of money that the system ends up paying for these people who are going for care is really staggering.
Yes. Thank you. Okay, last one. And then we'll go to the audience. I hope y'all are coming up with some great questions. And of course, this is about prescriptions. Let's see. How do prescription drug formularies, including specialty tiers, affect the availability of high-quality health service for underserved populations? Are formularies necessary? If not, why? Is that a good one for you?
Well, it's not my question,
Okay.
but I'm glad to touch on it a little bit.
Okay.
I think For me, for those of you who I've never met, I've seen some of you over the years, but I'm kind of new to this stage. I'm actually an intern in internal medicine at Cornell. And so the perspective that I'm bringing here is really one of somebody who's been in practice for about 3 months. And I have really fresh eyes. I know some of you were thinking that this was like bring a high schooler to a panel day. But, the perspective, on prescription drugs, I think one of the things that I've really noticed over the past few months in practice is that, with a lot of the patients that we see, and I'm at a federally qualified health center, a lot of the patients that we see, we're very limited in the medications that we can provide them. And I think it's useful to the extent that you have to have some standard by which our insurance carriers can determine what drugs to provide. But in the delivery of care, there are actually clinical reasons why we pick different drugs. So it's certainly a limitation. It's certainly a challenge. I think it's one of those that's very difficult to get around. So.
Dr. Puckering.
I certainly want to leap in here. I want everyone to know, I always confess every one of my sins before I start. I'm against formularies. I think they're discriminatory. I think they don't take into account medical need, genetic variation, age. They were created as part of the employer-based healthcare system to control wages. They have no place in the 21st century. They discriminate against minorities. I think we should be absolutely against them. And as we move towards really providing optimal care for a diverse America, we got to get away from formularies. And they add cost into the system. No one talks about all of the administrative costs associated with denying people access to quality medicines. So I think the minority community specifically should raise their voices in concern about formularies, period. And we're happy to work and run through the numbers with you to show how they disproportionately impact our communities.
You mentioned the administrative burden, and once again in Louisiana, we have 5 managed Medicaid plans now, and all 5 of them have different formularies. So you're already getting $33 per visit to see the patient, and then you have to spend an hour on the phone trying to get their medicine approved. There's no way you can memorize 5 formularies and know which formularies have which things. So it does cost a lot of time. Okay, so are there any questions from the audience? I don't know, I think that maybe that microphone in the middle is open. Do we have capacity to bring the microphone? Yeah. Yes, ma'am.
Thank you so much. Pat Tompkins, Black Nurses Association of Greater Washington, D.C. area. Now, when we talk about the Institute of Medicine, future of nursing work that they've done recently, and we talk also about affordable care, I think key to that in terms of health professionals is diversity. And we know that for nurses, with all that the IOM said we want to move to 80% of nurses with the BSN, the baccalaureate in nursing, where are Black people going to be? Because currently now many Black, probably the majority, I don't actually know the numbers, my executive director I'm sure knows, but most of the Black nurses are prepared at the associate degree level and at the licensed practical nurse level. So we need to do a lot. We need to get a lot of this. So my question is, what do we get in place so that when 2020 comes, that when we say 80% of the nurses are at the BSN level, that Black people, Black nurses will not be at the bottom. So, we have to start now in order to, and I know in Washington, D.C., where we do have a lot of baccalaureately prepared nurses, we also have a lot of nurses prepared at the associate degree and the licensed practical nurse. And a lot of this is because of our city, where we have our
training available.
University has a associate degree, a LPN program, and only an RN BSN program, not a generic BSN. So what are we going to do to get prepared, Black people, Black health professionals prepared to participate?
Well, that's a great, so she brought up a pipeline issue. She also brought up some standards issues. I remember when we did Healthy People 2000, then it became Healthy People 2010. Now we're going to go to Healthy People 2030. Because we keep making goals and not reaching them, but 80%,
Tell them to
what do you think
send
about
somebody to bring the
that?
microphone.
What do we have, Dr. Gorham?
Thank you, Pat, for Mrs. Tompkins for bringing that up. One of the major issues in terms of diversity that came out of the Institute of Medicine report on the future of nursing has been working through the AARP's Center to Champion Nursing. And one of the things that out of that center, they do have a diversity committee. That diversity committee goes across the breadth, including males, trying to get more men into the profession of nursing. But primarily, it's about the ethnic minorities and trying to get more minorities into, and making sure that there are more minority nurses that are practicing to the extent of their education and training. The states have put together what are called state action coalitions. They are, from every state has a state action coalition, including the District of Columbia. And within every state action coalition, there is a diversity committee. They are responsible for putting together recommendations on how we move that needle in a significant way in getting more nurses prepared at the baccalaureate level. Part of that says, folks in here, you need to reach into your pocketbook and send that money back to your health profession schools and send more than $25. You cannot get scholarships on $25. And that's one of the things on helping nurses going to broaden that diversity pool. The other part of that diversity pool says that we all need to take, as the gentleman said, people might have looked at him as a high school. We got to go back to the high schools. We actually need to go back to the middle schools and start mentoring children and their parents and their high school counselors and their teachers about the health professions and to get them involved in STEM projects, STEM programs, so that they can matriculate through these health professional programs. Money is the key, and that means not only all of us, but the healthcare institutions as well. When we're talking about did you ding me?
No.
Oh.
But maybe I should get a little bell. That sounds like I'll give you 10 months to finish that
Okay,
sentence.
I'll get to the second.
That was cute though. Who did that? No.
The healthcare institutions are moving in a very different direction. I was talking with one of our deans of school nursing last night, and she said based on the Affordable Care Act, they're making a paradigm shift on how and what they're teaching at the graduate level. They're going back to prevention and health promotion. Yes, we still need nurses in acute care settings, but they're taking them back in such a way that they're recreating what the nurses are learning and where they're actually going to take those experiences. And those experiences are going back into our communities, and therefore we need to have a broader, diverse population workforce in order to deal with those kinds of prevention and preventive healthcare services.
Thank you, Dr. Moore. And Dr. Lenore?
Yeah, very quickly, I'm glad that was brought up because we have exactly the same issue. 100 years ago, there were 3% African-American physicians. Today, there are 3% African-American physicians. In the last 10 years, only 2% of the physicians that have graduated have been African-American males. When we looked at the numbers of African-American students who entered into medical school in 2008 and the number that graduated, only about 50% of those students graduated. So we're very concerned about these pipeline issues as well. I think one of the things that she talks about is all of us know where we have to start at the level. We also are having trouble getting residencies for African-American physicians once they graduate from medical school. This year, 1,000 medical students did not match in the internship process. A disproportionate number of those were African-American. And so we're having exactly the same pipeline issues. There is a lot of lip service, to how we get people into these medical schools, but these are choices. The one thing that we are concerned about, before I get dinged, and I'm used to that because I live with a nurse, I've been dinged a lot. But one of the issues that we're concerned about that the Affordable Care Act will not take care of is what we call health care disparities. How you're treated when you enter the healthcare system, and how our young people are treated when they enter the medical and nursing system. So I think we all have the same issues. I think they go across the same lines. The solutions are probably similar for all of us, but we better be at the table, or you're going to look around and see that there's no opportunity for your children and your relatives and your friends to go into medicine, and I think or nursing, unless we get, and dentistry, I'm sure is the same issue. So that we do have those same pipeline issues, and thank you for bringing that up.
You want to say something?
And briefly, there's a tie that binds here. There's an estimated physician shortage of about 45,000 primary care physicians by the year 2020. And so one of the things the Affordable Care Act did look to do was expand the number of primary care practitioners that we have. I myself, I'm in a primary care training track in internal medicine, and a lot of these positions were made available because of the Affordable Care Act. So there were a lot of funds that were dedicated to this purpose, both in primary care medicine, about $168 million, in nursing for nurse practitioners, about $30 million, and for physician assistants, about $30 million, to build that primary care workforce. And I think there's some merit to that. And it was 5-year grants, and those started in about 2011. I think they'll be running through 2016, if I'm correct. But the idea is they're aiming for physicians, at least, to add about 900 new primary care physicians that wouldn't have been there through the match, as Dr. Lenore mentioned. And so, certainly the efforts to increase the number of primary care providers are there, but they're still inadequate. 900 physicians to a 45,000 physician shortage. And this is in the setting of a 32 million individual expansion of folks trying to go into the health systems.
Last comment on this one, because other folks have questions. Go ahead.
Okay, even with all this, one of the problems is that, it is more competitive to get into healthcare training schools at this point in time, and many of our students aren't prepared. So, the statement that was made in terms of we need to go back into the middle schools and the high schools to get students prepared to get into professional school. Otherwise, we're going to be in the same place that we have been previously. We have not promoted our professions as well as we used to. There was a time in the 60s and in the 50s and what have you, if you were a physician, a dentist, or a teacher, there was a certain amount of esteem that came along with that. And now, the respect level has dropped, and so kids aren't looking to go into it. So we have to continue to promote our professions and elevate that so that people want to go into the profession and will prepare properly to go into the profession.
Thank you. All right, there's another next question.
I think my question probably has been answered, which is basically, what is it that we're doing as far as being able to ensure, I'm a primary care physician, I'm a family physician myself, and I remember back in the early 90s when Clinton, there was no child uninsured, and we had children coming out the walls. And me as a physician who was on burnout mode, and I know the information has actually been spoken to in terms of the funds being available, but how do we actually translate what's on the books into real action in terms of ensuring that we can get grants for cities? I mean, is there a place that we can get this information? Are there persons to actually help us to write grants to ensure that our medically underinsured areas are going to be covered? Are historically black medical schools?
That's a long question.
They in trouble. So, it's been partially answered, but I initially was addressing my question directly to Dr. Lenore in terms of what is the National Medical Association doing specifically to address this problem?
Well, we're doing this. We're trying to form effective partnerships with people. We can't do it as an individual group of about 8,000 active physicians. So we need partnerships. Part of it has been our responsibility to solicit these partnerships, but I think probably Dr. Pickering can answer that.
I always attack these things by first understanding a little bit about the geography of our country and where we African Americans are. So there are about 38,000 zip codes in the United States. 70% of all African Americans live in 1,500 zip codes.
Right.
That's the number. And we haven't built infrastructure and connected those communities And it's going to take leadership. I'm sorry. It's going to take leadership and commitment to build community, to establish those pipelines through the schools. There is no, one of the challenges that happens now as America becomes more diverse, it means that it's a little bit of every man for himself in terms of maintaining and developing your community. And so from where I sit, it's not a big puzzle. It's 1,500 zip codes. I think when we probably go down and look at the number of elementary schools and high schools in those communities, I'd be shocked if there are more than 400 or 500 of them. And it's right there in those 400 or 500 schools where we got to get the job done. And so somebody's got to stand up, take leadership and say, we got to build community, build pipeline, and take advantage of the resources. I just want to make this final point. There's a group of Hispanics down in McAllen, Texas, built a hospital called Doctors Hospital. I've had a lot of interaction with them and what they've done down there in Southwest Texas. They now have a medical school, and they have built community. I went to a meeting for the hospital down there. The teachers were there, the police officers were there, the banker was there, the mayor was there. They were all there, understanding that they all had a stake in the challenge, and I think that's basically the message that I would deliver.
Yeah, and just about the money for primary care. So we've done that before. What tends to happen is people get their internal medicine residency, and then they apply for a fellowship in cardiology and nephrology because they have to pay back their $200,000 loans. And so the challenge I would say is once this grant expires, how many of those people actually are practicing primary care in a neighborhood that is underserved, and what is the mechanism to make sure that people that you give money to do primary care in an underserved area actually stay in that underserved area and work in primary care. So,
and some of that, just to briefly answer, some of that is the expansion of funds for the National Health Services Corps. But kind of to your point briefly about physician burnout and the number of patients that individuals have to see. Formerly I was the national president of the Student National Medical Association, and a lot of what I would say is that it takes about 11 years to grow a primary care physician. 4 years of college, 4 years of medical school, 3 years of residency training. And so if you think about it, there's no way that we're going to achieve, the numbers that we need by 2020. It's going to take a lot of patching together different kinds of providers. One way that the Affordable Care Act really aimed to do that was through community health centers and kind of expanding the number of people utilizing those. And currently I work at one in Long Island City, New York. It's actually situated between Queensbridge projects and Ravenswood projects, so we have really over 10,000 underserved residents right there, and they're all, a large percentage of them are utilizing our facility. And I think, there were a lot of monies that were available, $11 billion, I think, for community health centers, and so I think that's one of the mechanisms, but really, it takes these concurrent processes of encouraging the young individuals to go into these fields, but also making the most of the resources we have available now. So.
Good morning.
Good morning.
Since the teeth, the jaws, and the mouth seem to be no longer part of the body, though the evidence shows that periodontal or gum disease negatively impacts diabetes, cardiovascular disease, as well as the incidence of low birth weight babies. Yeah. I'd like to know what we can do to encourage our physician as well as our nursing friends to slow down when they ask the patient to open their mouth and don't just go directly to the tonsils when they're evaluating their general health.
Okay. You can have that, Dr. Leno.
I think that was kind of directed at us. But here's the problem. We recognize and we work with the National Dental Association that the mouth is really the gateway to the body. We know that. Heart disease, all the things that you mentioned. The problem we have is that when we identify that and we try to find dental resources that the patient can actually afford, they're just not available. Right. I mean, most of the dental insurance is not adequate even for private, for private pay patients. So our struggle is not that we don't recognize it. Our struggle is trying to find places where we can send our patients, that especially those that don't have adequate dental coverage, to get the kind of care that they need. But we do absolutely recognize how important dental care is in the whole stream of the healthcare system. So it's not an issue for us. We're very updated on that particular issue. But we cannot find dental resources for many of these people.
Yes, ma'am. Who has the microphone? Oh, right here. Okay, sorry.
Hi, good morning.
Good morning.
First, I just wanted to ask the panelists if all of y'all would pull your mics forward so we don't have to listen so hard. It was a little hard back here. I am a practicing gynecologist in Prince George's County, and I practice with my husband, who's an internist and a weight loss physician. And we are really like dinosaurs out here. I remember back about 10 months ago, our hospital, Doctor's Hospital, had a meeting for physicians to come and listen to a presentation about ACOs. Now, the interesting thing that I noticed about that was that the physicians who were in charge of setting this up were physicians, most of which weren't born in this country. And they were not physicians who were in that planning session who even were familiar with what was going on. Additionally, they were only wanting to include primary care physicians in the ACO. And when they discussed this with us, you know, it's, excuse me, it's always a financial issue. And they were discussing it with how returns would be made, and it would be such that the people who had developed the ACO were the ones really who would reap the benefits. That was what was to be expected, but the concern was that we were really not at the table, just like you said, Dr. Lamar, and congratulations also on your installation.
Yay.
But that was a concern because, you know, I'm always looking at that. I take call at that hospital for uninsured patients who come into the emergency room. Probably 95% of the women that I see have no insurance. And many of them are not eligible to be able to get Medicaid to cover the hospital. So therefore, you got another issue with hospitals, and now I'm concerned about that too. The other thing is, I was at a meeting of the the Dominion Medical Society, which is a minority medical society in Virginia, the branch that was in Virginia. And this was just recently, 2 weeks ago, and we don't know, we don't have the information that we need to know about forming ACOs or being part of this whole question or being in it. And we really are concerned, and we really didn't have the knowledge to know where to go. So it's exactly what you're saying here, and I think that we even at that meeting when we had someone there who was talking to us about it, they were coming from outside, from another state, and it's just a concern that those of us, and in Prince George's County, it is a real concern. The minority physicians that are black minority physicians actually don't have real ability to know what to do at this point.
Okay.
And that's what I'm hoping, that's why I came today, because I was hoping that we'd be able to get some information, some knowledge as to help us to navigate this, because certainly we don't want to lose our patients. And we are very busy. We work very hard, as you all, everybody knows. And we are burned out. And so that's my question.
Thank you. So, Dr. Lenore, I think the core of that is the ACO question, which we hear everywhere. We only have 5 minutes left for our session, so we're only going to have one person these last 2 questions.
All right, I'd like to answer that very quickly. What we call this really is the black hole in the Affordable Care Act. About 70% of these patients are currently taken care of by people in just your situation. And many of our doctors have no idea about what's to hit in terms of both the quality measurements and their ability to practice among the very same patient population that they traditionally serve. What's not said about fairly qualified health centers is that their reimbursement rates are about 6 or 8 times ours, and we don't have the corporates. But what we are doing is what we're doing here. We're letting people hear what the problems are. I think it has been our fault to not have been at the table more aggressively as these problems have evolved. But now that we're here, we are going to be more aggressive in trying to get our voices heard. We have partners in this room, and that's why we have this opportunity. But believe me, we at the National Medical Association are concerned about all the issues that have been brought up here, and we're working very, very hard to change language, to get information out. But we're behind the curve, but we're working much harder.
Okay, who's next right here?
I just wanted to say thank you all, first of all, to the conveners of this session. It's very well needed, and to our friends up there. I'm a past president of the National Dental Association, Dr. Hazel Harper, and I just wanted to address the issue of interprofessional teams and the training and skill sets that are required for us all to be good members of that team. My data and research showed that 69% of the medical schools in the U.S. said that they receive 5 hours or less of any training in oral health care or dentistry, and the rest of the remaining 30% receive less than that. So it has been our experience that not so much that there aren't available providers to whom to refer the patients, but it's our experience that with 2.1 million dental-related emergencies going into the ERs, that translates into 2.1, upwards of over $2 billion in expenditures related to dental-related emergency visits. That part of the problem truly is that a lot of our non-dental health professional colleagues do not have the necessary training to be able to help us to be able to be good referrals and form good referral networks for the dentist. So I'd really like to ask the question, is there any movement that will include more training in the medical school nursing curriculum that would allow the nurses and the physicians to be able to at least diagnose dental illnesses or dental problems, because that doesn't exist to the extent that it needs to?
I don't know that we have.
I mean, I could speak from my experience. I think that anecdotally, you're probably right. There's a dearth of information provided to a lot of medical students on dental emergencies, and I think that the same can be said about a lot of medical conditions. I think medical school as a whole, you can't cover everything in extraordinary detail.
Right.
But I will say that it's really important that we hear these kind of issues from you, and it's the start of change. And so I think that's a starting point. And the other thing is just that I think there are a lot of referrals. I know even in the last week, I can't say I was trained particularly well by my medical school on dental emergencies, but I made 4 referrals to dentists in the last week at my clinic. So it's not to say that we don't look in the mouth or we don't see poor dentition or those sorts of things, but it's to say that I think both problems are kind of concomitant. So.
Right.
No, I said my anecdotal experience. Yeah.
Right.
Sure.
Yeah, even as a gynecologist, we think that they don't learn enough about the vagina, and they're always sending people to us instead of just figuring it out. So I think all of us, it's kind of how that goes. So anyway, yes, ma'am. Last question.
Good morning. Esther Beeks, National Dental Association. Once everything is in place with the insurance coverage and so forth, I would like to know, will there be any options if you don't like a particular plan that you're in that you can change to or something?
Yeah.
Will that be available?
That is really a very, very important question. It's the question of mobility. And no one has really answered that.
Right.
I have not seen anything come out of HHS answer it. But you should fight very hard for it and watch very, very carefully, because the marketplace is going to want to lock patients in and slow up their ability to move. And the minute that happens, consumer choice is going to go away. And your leverage, be you a dentist or a physician or whatever, is tied up in that mobility question. So I know it's being researched right now. I don't think there's been an answer that I've seen, either at the state level or at the federal level.
Yeah, I haven't seen. I see 2 people standing, and I know we're over time. What do you want me to do? Right here? Did you have a question in the red?
That we all become more educated in the expanded role of dentists, physicians, and nurses. For the accountable care organizations to work, we have to look at the training and the talents of all professions. In respect to nursing, health policy is part of our curriculum at Howard. I have graduate students in nursing. They're being trained as nurse practitioners. Last weekend, we were in Baltimore with Congressman Cummings.
Last one? Yeah. Okay, no. This gentleman here, because we're already over time, and I think you've been standing for a while. You, right? You wanted to ask a question, sir?
We know that there are students, African-American students, that are in these schools, and we know that where they are, who they are, and we can have possibly the National Medical Association as well as the Dental Association can be the conduit, or the clearinghouse for those students if they allow us to come to the table. And that's been the problem. We just haven't been able to get to the table.
Thank you guys so much. This has been a great panel. I want to thank our panelists. Yes? Yes. Okay. I want to thank our panelists for coming out. Dr. Lenore, Dr. Puckering, Dr. Gorham, Dr. Cameron Webb, and Dr. Chappelle. Clearly it's important that we get more involved as a group and having all the specialties together. Thank you guys very much.